Good evening, colleagues. We are a group of interns at Al Zahra Hospital presenting a brief demonstration of eye examination. So, starting with a small reminder of the eye's anatomy, here we have the cornea, that is a transparent dome-shaped structure allowing light to enter and playing a great role in the eye's reflective power. After that, we have the conjunctiva, that is also a transparent mucous membrane, further subclassified into palpebral conjunctiva below the eyelids and bulbar conjunctiva covering part of the sclera. Sclera itself being the white layer of the eye. After that, we go into the iris, that is the colored part of the eye, composed of muscles that, that constrict according to light to control the amount of light entering the eye bulb. After that, we go into the vitreous humor, and the innermost layer is the retina, where we have photoreceptors, rods, and cones. So, after introducing ourselves to the patient, here starts our ophthalmic physical examination. The first step being the inspection, where we can have, for example, conjunctival pallor indicating that the patient may be anemic, exophthalmos indicating that the patient may have hyperthyroidism, scleral icterus indicating that he may have a hepatobiliary dysfunction, and ptosis that may indicate myasthenia gravis or Horner syndrome, among other differentials. The first exam to do is to test the visual acuity of the patient. To do so, make sure that the patient is wearing his eyeglasses if he already has one, and start by testing the distant vision where the patient is sitting 6 meters apart from the Snellen chart, then testing the near vision where he sits almost 33 centimeters from the chart. After that, record the smallest line the patient can see clearly. Repeat the exam for each eye separately. Then, if the patient has a problem in his visual acuity, go for the pinhole test. If the vision improves with the pinhole test, it's most likely a refractive error such as myopia or hypermetropia. If vision didn't improve, go for another pathologies such as corneal opacity, cataract, retinal disease, and others. Then we have the pupillary reflex test used to assess the integrity of the optic nerve as afferent and oculomotor nerve as efferent. We have the direct reflex test where we shine light into one eye and normally its pupil constricts. And the consensual light reflex where we shine light into one eye but the pupil of the second eye normally constricts. After that, we have the swinging flashlight test where we alternate light from one eye to another. If the second eye's pupil dilates instead of constricting, this indicates an RAPD, that is a relative afferent pathway defect, indicating a probably defect in the optic nerve. Here we're doing the H pattern in order to assess the extraocular muscle movements. As we know, we have the cranial nerve number 4, the trochlear nerve, innervating the superior oblique muscle, abducent nerve, cranial nerve number 6, innervating the lateral rectus muscle, and the oculomotor nerve, the cranial nerve number 3, innervating all other muscles. And here we're testing the visual field by confrontation. That means that both the patient and the physician sit in front of each other and close their opposite eyes as seen by the video. Then the physician moves his finger away until the patient says that he is no more seeing it. After that, the physician compares the results to himself, and same is repeated for the second eye. And here we have the slit lamp examination, which demonstrates any abnormality in the anterior segment of the eye, which is from the cornea until the posterior part of the iris. Some abnormalities that we see are cataract, keratitis, and Kayser-Fleischer ring, such as in Wilson disease. In opposite to that, and in order to assess any abnormalities in the posterior segment of the eye, which is from the posterior part of the iris until the retina and optic nerve, here we have to use the endoscopy. Some abnormalities that we can see are diabetic retinopathy, retinal detachment, and papilledema. However, if you want And in order to measure the intraocular pressure, as for glaucoma screening, for example, we can use tonometry. Tonometry has three ways. The most accurate is the applanation tonometry seen in the picture. And as for testing for strabismus, we have three different ways. The first being the Hirschsprung test, where we shine light into the eye, and if the light moves towards the temporal area, that means that the eye moves inward and it is esotropia. The opposite applies to the exotropia, where the light moves towards the nasal area. Also, we have hypertropia, where the light moves downward, and hypotropia, where the light moves upward and the eye moves downward. The second test for strabismus is the cover test, where we cover one eye and look for the movement of the second eye. If the second eye moves outward, that means that it was deviated inward, and we have esotropia. Oppositely, if the eye moves inward, that means that it was deviated outward, and we have exotropia. Same applies for hypertropia and hypotropia. Then, if both previous tests were negative, we go for alternating cover test to check for any phorias that are masked strabismus. So we cover the eye, then uncover it. If the eye itself moved outwards, that means that we have esophoria. Oppositely, if it moves inward, that means that we have exophoria. And if you want to assess the lacrimal gland function, here's Schirmer test can be done, where a small strip of filter paper is placed inside the lower eyelid and the amount of wetting is measured after 5 minutes. Normally, we have to have more than 10 millimeters of wetting, but if we have less than 5 millimeters, it may suggest Sjogren syndrome or others. The last idea we want to tackle here is the importance of the eye examination in detecting some neurological diseases. For example, if we see the horizontal gaze is paralyzed, we may think of central pontine myelinolysis that occurs in the setting of overcorrecting hyponatremia. Also, if we see vertical gaze paralysis, this may indicate progressive supranuclear palsy, that is a type of Parkinsonism. And here's our presentation comes to an end. Thank you for your time and your attention.